Hello friends, we are here from PACS 2018 and we've been having great discussions since morning. So with me we have the very famous and the very well-known Dr. ROHIT SARIN, who is the Director of National Institute of TB and Respiratory Diseases. He has moderated a wonderful session on management of chronic empyema and he's going to enlighten us about a few topics. So sir, if we have a patient who has a loculated empyema, how would you like to approach this patient? Please tell us.
Thank you. First of all, I would say it's a great opportunity to interact with all of you on this particular issue. Yes, the institute from where I come, the NITRD, we are having a full-fledged thoracic surgical unit, and that is really doing a lot of work on the chronic empyemas, multiloculated empyemas, and of course also a lot of surgeries are done there as part of the activities. And we are also running a super specialization DNB thoracic surgery. We're one of the first institutes in the country to start that. Now, you see, the morning session which I moderated basically talked about a patient who has had multiple loculations, and the issue was how to manage this particular patient. And when we talk of a patient who is having a multiloculated empyema, I think the first thing is, of course, we have to move towards what's the cause and treat that. If it's tubercular, then you'll have to give anti-tubercular treatment. If it is pyogenic, you'll have to give antibiotics and so on. That is one part of the story. But at the same time, we also know the dictum that pus anywhere has to be drained before we are able to bring about a successful cure. And for that, there are different options which are available. One of the options which is available is that we put in intercostal tube drainage. That is the normal thing which we have been doing for decades. I mean, it's nothing new in terms of technology. It started way back in 1950 and it carries on. So an intercostal tube has to be put first of all, and to break the loculations we have been using some fibrinolytic agents, streptokinase, urokinase. These are different types of fibrinolytic agents, and newer generations are coming up, and essentially the idea is to break the loculation, which will help in drainage of the pus. However, there are situations when we really do not know the cause, and in that situation this particular intervention may not tell us the cause. So for that we need to really view it through a pleurovideoscope. So that is the medical thoracoscopy, so to say, what we call it, and we put in this scope through the chest and we try to visualize the pleura, and there definitely we will get to see the lesions. We may be able to take a biopsy from the lesions and also in the process break the loculations. So here we have broken the loculations and we have taken something from the pleural surface for bringing about a histological diagnosis, and this is a big advantage. However, you see, if the diagnosis is more or less known based on the clinical history and the examination of the patient, then pleurovideoscopy could be avoided, because this is a technique which requires expertise, more expertise I would say than just putting in a tube, and the availability of the equipment and so on in different centers. So therefore I would say that the preferred option, the first option in hospitals around the country would be to put in an intercostal tube and to do fibrinolysis. However, if the diagnosis is uncertain, then you refer this patient to a place where pleurovideoscopy or medical thoracoscopy is being done.
Thank you. That was, very nicely and lucidly you told us when to just put ICD and use fibrinolytics along with IV antibiotics, and when to actually intervene with medical pleuroscopy. So sir, I want to ask you, when is the time when we actually want to do a proper VATS for this patient?
Okay, VATS is basically a domain of a surgeon, and the physician cannot do VATS, and they have to do it under general anesthesia, and there is a particular procedure which is involved in this entire thing. We don't want to initiate it too early. We need to do it only when we feel it is required to be done. And in that particular context, I will say that if a patient is not responding to our medical management, then we should think of this particular surgical intervention. When I say not responding to our medical therapy, the next question which automatically comes is, for how long do I wait? I have put in a tube, now for how long do I wait? So this is something what we call as defining a chronic empyema. You see, chronic empyema would be a situation where in spite of good proper drainage, the lung is not expanding. Over a series of x-rays, if we see taken a week, 10 days apart, and we find that the lung is not expanding in spite of a good drainage, that means that basically there are other factors which are preventing the lung to expand, and one of the most important factors is formation of a thickened pleura over the lung, which is preventing it. So in that context, definitely we will have to do VATS and we'll have to do a decortication procedure. Then again, you see, there would be situations wherein we find that the drainage keeps on coming. We have waited for 4 weeks, we have waited for 6 weeks. So in terms of time frame also, when the drainage is continuing to drain even after 4 to 6 weeks, then we think that it is chronic and we move towards a surgical intervention. Now there are different procedures which are being done. There is what we call as a window, percutaneous window is formed to do a constant drainage. We send the patient home because obviously such patients cannot be kept in hospital for too long a period also. So to send them home, we do a minor procedure. We open a window and let them go home. But if we have to do a larger operation like decortication, then we will call the patient back after a period of time and we'll do a decortication. Sometimes in such situations we also have to do a thoracoplasty in case the patient is not responding even to decortication.
Thank you very much. In a very nice way, you've taken us through the entire array of the difficult management of a chronic multiloculated empyema. Now we exactly know when to put an ICD, when to use fibrinolytics, we know when to do medical fluoroscopy, and we know when to do VATS or do decortication or do a window. Thank you very much.
Thank you so much for giving me this opportunity.